Here we go. So, welcome to our town hall. We've been, I should say, a little bit late in getting our next one going because of many transitions in our practice. So I am going to just give myself a little reminder here. So let me get started with our little slide presentation. Here we go. And that's the wrong one. Stop share. Here we go. Screen share. Keynote. Town hall. Share. Let's see if that brings it up and play. So anyways, as you notice, there have been many changes at the office. Last year, Mara left after 15 years. She was ready for a change and moved on to Mass General to the vascular floor. And following that, we brought on board Janine, who's now been with us a year. She has a lot of experience in rheumatology, and it's been great, really, to have her come on board and provide us with some expertise with her background in both pain management. She worked many years in a pain clinic, as well as her many years working with Dr. Conte, a colleague of mine in Rhode Island, as a rheumatology nurse practitioner. So we are thrilled to have her as part of our team. We also have new staff. Sandra Pires has joined us at the front desk. She is now our discharge exit receptionist and helping us as she gets familiar with all of the intricacies of running a practice and finding out where the keys are, so to speak. As you know, Paula departed after 20 years to take care of her parents, and we are sad to say that both her parents have passed in the last 2 months, her father 2 weeks ago and her mother 8 weeks ago. So it was time for her to step aside and take on the duties of providing care for her parents, and we were happy that she was given that opportunity to be at home with them. We hope we can sneak her back for 1 day a week, but obviously she needs to recover and recoup and find her footing after a long time. We also have Kelsey Walsh, who has joined our staff as a nurse practitioner. She is familiar and a trainer in training in Ayurvedic medicine, spiritual medicine, and has a keen interest in group meetings and practices to provide a path to wellness. We are excited about her interest and expertise. She is again getting her feet wet with how the office works, the technologies we use in the different interfaces we have, from our alignment with the hospital, with Mass General, with Partner Brigham. Since Paul has left, I now have 38 websites I sign on to on a regular basis and have to change my email. And that brings us to new technology. We have been on Quest Diagnostics. As you know, Quest is a national laboratory system. We signed on with Quest 15 years ago to facilitate the fact that the basic information within the Quest system allowed us to upload and begin using the electronic medical record immediately. Our punishment for that ease is that they have decided to sunset. So we are trying to limit new patients coming on board. As you know, there have been many shifts in the community. Compass Medical closed, basically setting 70,000 patients free into the wilderness. Social Medical Center has had a significant change in their provider profile, and the hospital is struggling with staffing like every office, hospital, clinic, and emergency room. So I do ask for patience. I know it seems that the wait can be long, but I have to act in the role of practice management as well as provider while we try to restaff and look for people who are comfortable and competent with the transitions that are happening. In December, our electronic medical record system will sunset. which means we will no longer have a dynamic access EMR system. We are onboarding Athena Health over the next 90 days. It's supposed to be 60 days, but we're hoping it takes 30 days. So bear with us while we try to perform that miracle. Many of you have been getting text, email, and office visits scheduled. You are not bound to that office appointment. However, you may call and opt into a telemedicine or an in-person. We are trying to, in the last quarter of the year, round out our quality metrics. And what does that mean? Well, there are Medicare wellness visits. Those can be done in telemedicine. They are not a physical. The wellness visits are to update and record basically what is population management. So those yearly physicals can take place. We call them yearly wellness or updates via telemedicine in the office. Your yearly physicals, I do want to also for new staff, not new, but returning after 5 years, Sharon has returned to help us out with the primary care piece in the physical. As you know, she is an expert at the physical. No one can do it better than Sharon. She gets the job done. And I have to tell you, the number of people that have put off having their physicals and the number of findings in the past few months have been astounding. So I do recommend that you do come in, check base. We want to make sure that we're not missing melanoma, uterine cancer, ovarian cancer, colon cancer. And we are held to population metrics and quality metrics. And that is the other reason for the physical and the wellness exam and the yearly updates. We must manage your blood pressure. 140/80 is the target. If you are over 140/80, you must come in and have your blood pressure medication adjusted, or you must provide us with an in-home blood pressure that meets that metric, 140/80. If it's 82, we get discredited. So we lose points. As we lose points, our withholds are all taken away from us and given to other physicians in the community. We also have to manage your diabetes, cancer screening, eye exams, and make sure those are all up to date. We are in a push over the last quarter to try to have those metrics in place so that we can maintain our contracts with the insurers. The other one is, many of you know that with these changes, Leslie, our nurse who is also our nurse nutritionist, and also has taken over the prescription line. I ask all of you to have patience with the prescription line. We are putting in the prescriptions on a daily basis. We ask that you give us 5 days. We are working 7 days a week, clearing the physician line. Nobody can continue working 7 days a week. So I'm asking that you have some patience. And with that, you have to understand that the pharmacies are calling us because they don't have staff and they are struggling to even answer the prescription line. So they are asking that we tell patients that there may be 5 days before your prescription. They tried to do it within 24 hours, but many of them can't clear because they can't clear the prescription line, fill all the prescriptions. And finally, there is a supply chain issue with many controlled substances. So again, yelling at us, upset with us, doesn't help anything. We are doing the best we can. So I do really want to ask that all of us participate 100%. And with that, I will, if anyone has any questions, please write it down, roll it up, and light it on fire. Oh, and now I want to bring you to the exciting part of our evening. And this is Dr. Theodore Henderson, who I have met over many a cold laser and not any drinks. So we have to correct that, Theodore. So he has been kind enough to be here and help us understand the future of mental health. Theodore, or Ted, as I call him, he has an amazing story to tell. His life story is amazing. His most recent book, which is Brighter Days Ahead, is worth a read. I enjoyed every minute of it. And it really shows the journey from a young man, from a small boy, against all odds, struggling in his own life to achieve incredible milestones, not only going to medical school and getting his MD, but also pursuing a PhD. He clearly has performance anxiety. So he is here with us to, as you know, we have been on the journey for improving everyone's mind. As I spend the last 40 years providing healthcare, I understand that if I don't put the mind at peace, I cannot put your body at peace. Whether it's rheumatoid arthritis or colitis or back pain or disc disease or degenerative disease, the final step, the last mile, as we say in computer technology, it is that last mile that really is the fruition of all the work that you do up to that point. And it is the hardest mile in many ways because you have to make that commitment. But we see every day with some of what we've instituted, as you know, we have brain tap, we have low energy neurofeedback, we have the Aspen laser. We are doing so many wonderful things that are exciting. It's what keeps me practicing every day, to have people come in and go, I slept for a week. I never felt so well. My arthritis doesn't hurt anymore. I am now driving a car. I am lowering my prednisone. I've decreased my pain medications in half. So we never give up, and we're always trying to provide you with that opportunity to be as healthy as you can and be the best that you can. So without further ado, I will let Dr. Henderson introduce his path and provide us with information about the future of mental health. Dr. Henderson, thank you so much.
Dr. Hopkins, thank you so much for inviting me, and it's a pleasure to be here. And you know, I wrote this book. Well, I wrote this book because there was a pandemic and I had nothing else to do. There's a point where you had to stop drinking. And you had to do something.
10 o'clock? Really? You're kidding me. All
So,
right.
But I wrote the book to educate and empower people, particularly people struggling with depression and PTSD. And the book, of course, evolved. When I originally wrote the book, it had, you know, much of what it has now, which is in many ways a very casual conversation about depression. And then peppered throughout are stories of real patients' experiences, and sometimes quotes from patients themselves. But then I got, you know, I'm a science geek, so I got very sciencey. And so I had to figure out a way to like not bounce back and forth between deep science and, you know, writing something that anybody could read. So the book really is kind of two parts. There's the first part, and then at the back of the book, if you get curious, there are deep dives, which really get into the science and all the kind of elongation factors and eukaryotic this and that and cyclic GMP and all of those kind of fancy scientific terms that most of us don't really need to know. And I also devoted one chapter just to sort of my experience as a graduate student doing research, and which talks a little bit more about just how science really works. And it's not what we think. It's lots of long hours doing the same repetitive thing over and over and over again. And, you know, it's definitely not a spectator sport, let's put it that way. So,
and I always, you know, I always think about the term, we do evidence-based medicine. Well, if you're really doing medicine, you shouldn't rely on the evidence that's in play without either having done your own research or querying or balancing what you read so that you understand the limits of even that statement. It's a statement, and I always thought it was a false statement. And if you're doing evidence-based medicine, you should go home.
That's a great point. And so I'd like to use a PowerPoint to just sort of, you know, throw some fun science into all of this, and as well as kind of give people a sense of how medicine and psychiatry has the potential to change.
So I'm going to make you co-host, which I think allows you to then share your slides.
Let's see what happens if I hit share. Yeah, it looks like it'll work just fine.
Okie doke.
Yeah. All right. Let's see here. Kick this off.
I will say that Dr. Henderson and I met over the concept of photobiomodulation and applied quantum biology. And people say to me, "Oh, you're going to laser me," and they think of it as a burning pathway, and instead it's an illuminating pathway to a healthy brain. So Dr. Henderson is going to expound upon what we've brought into the office over the last year.
As well as to start with kind of, let's start with where things begin. Right now in medicine, there are all these mostly brain-based disorders for which we have lousy treatments, or we have very costly treatments, or we have no treatment at all. Alzheimer's disease, there are very costly treatments. There's almost no proof that they actually help. Yeah, they get rid of the amyloid, but they don't improve the dementia. Post-COVID fatigue syndrome. The federal government has spent millions of dollars researching post-COVID fatigue. We know exactly what it is. We have no idea what to do about it. And that's a little bit of why the problem that I decided to tackle. And it's wonderful to have colleagues like Dr. Hopkins who is tackling it, and we're actually coming together because we're finding that she's got some tricks that I don't have, and vice versa. So this is the book, Brighter Days Ahead. And really, it is about leaving depression behind. And it's about rethinking depression. So I'm going to say something a little shocking. Serotonin has nothing to do with depression.
Thank
Nothing
God.
And the proof is in Prozac, because Prozac, if you get put on Prozac and other SSRI, it's like, okay, you wait around 6-8 weeks for it to work on your depression. But in fact, Prozac increases serotonin levels literally within hours. It is in fact used, Prozac, fluoxetine, it's sold under another name, Serafem. And Serafem is given for premenstrual dysphoric disorder, what we all call PMS. And you don't take it all month long. The woman starts to take it 3 days before her menstrual period, takes it through her menstrual period, and stops. And the reason that works is within hours, Prozac increases the serotonin levels. And that is, PMDD is one disorder that is very clearly regulated by serotonin. So it works within hours. And in fact, there have been a number of large studies that have looked at serotonin and depression. And this meta-analysis was just published in Nature, which is like one of the top journals in the country, in the world. And it was what's called a meta-analysis, where they take a bunch of different studies and they take all the data from all these different studies and they put them in a statistical blender, and they get a number out the bottom, and it basically said serotonin and depression have nothing to do with each other. And out of that paper, I'm just going to read the quote. Our comprehensive review, and I can't see it all because it's partly covered, of the major strands of research on serotonin shows that there is no convincing evidence that depression is associated with or caused by lower serotonin concentrations or activity. Most studies found no evidence of reduced serotonin in people with depression compared to people without. And methods to reduce serotonin availability, such as certain chemicals, do not consistently lower the mood in volunteers who take these chemicals. What is depression really? Depression is a degenerative process that attacks your brain and destroys neurons, breaks down synapses, breaks down circuits. And you can see that here in an animal model. So here's a normal healthy neuron, and here's all the dendrites, and this is the axon, and it's going up and branching extensively at the cerebral cortex surface. And here is the same type of neuron in an animal that has been experimentally made depressed. And how do you make a rat depressed? Well,
You take away the cheese.
well, no, or send them to law school, one of the two.
Yeah, right. Well, if they're a rat, they'll do fine. Yeah.
You have a metal floor of the cage, and they intermittently electrify it. And they keep doing that just randomly until the rat just gives up and lays there. And that's the definition of a depressed rat. So you see there's lots of branches in both the dendrites and the axons. And here a close-up of a dendrite. These little spines are where the synapses occur, synapses being the little connections between one neuron and the next. And in the stress animal, you can see how few spines are left. So in fact, depression is a degenerative process that is destroying particularly the frontal cortex and also the hippocampus. And the hippocampus, for those who, it's not exactly where hippos go to school, but it's tucked right in the back of the medial temporal lobe. Here's the temporal lobe. And you can see it here in a horizontal view. And in studies going back many years, they looked at the volume of the hippocampus and saw that in depression, it dropped, a good 40%. The frontal cortex, harder to measure back in those days when they're doing these MRI studies, dropped about 10%. The subgenual part of the frontal cortex, that is the part right above your eyes, dropped a whopping 50%.
So what is the hippocampus responsible for?
Hippocampus is involved in learning and memory, and as well as it's part of the pathway for emotional regulation.
So is that why in Alzheimer's we measure the hippocampus volume, we see that going down?
Correct. Yes. The hippocampus. I mean, the hippocampus is the oldest part of our brain in terms of cortex. It's made up of 3-layer cortex, while all the rest of our brain is made up of 6-layered cortex. But since it was our first cortex, we couldn't afford to take it offline during evolution to replace it with something else. So we've been sort of stuck with, this very old rickety piece of cortex that is essential to learning, memory, and emotional regulation. Probably more than you wanted to know.
And what about the
And go ahead. Once there's a loss, can you restore it?
Well, this is what we're going to talk about in a moment.
Right. That's what I want to know.
And what about
because depression does resolve for some people, right? So does that mean they restored that part of their brain?
That's exactly correct. Yes. Yeah. You've seen this talk already.
Yeah.
No, I haven't, but I'm hoping that's where it goes.
So one of the critical factors in the brain is a factor called brain-derived neurotrophic factor, or BDNF to its friends. BDNF is a driver of neuroplasticity in the adult brain. BDNF also protects neurons from toxic injury, and the type of de-arborization and breakdown that we see in depression, and the same thing happens in PTSD. And so when BDNF levels are increased, then it induces arborization of the dendrites and new synapses and new circuits and even pluripotent stem cells to leave and grow into being full-fledged neurons and take up residence in the hippocampus. And only just recently have we actually found evidence that actually works, that neurons can successfully integrate into the circuitry in the human hippocampus. So BDNF, brain-derived neurotrophic factor, is an essential part of this activation of neuroplasticity and recovery of the brain. So how do we turn on BDNF, right? That's the big question. Well, ketamine is one of the answers. Ketamine has been around since the Vietnam War. It is an anesthetic. It's what's called a dissociative anesthetic, and that's part of the reason it's abused. But it's also one of the safest anesthetics. It's the most widely used anesthetic in children's hospitals because it is so safe. And in very small doses, about 10% of the dose used for anesthesia, it is a very potent activator of BDNF and therefore a very potent antidepressant. And here's one of those deep dives into the science, and I won't beat you up with it too much. But basically, when ketamine activates a certain receptor, and it has to have another receptor that's in the proper configuration, it activates the release of BDNF plus the upregulation of receptors for BDNF, what are called the TrkB receptors. And so we actually see increase in receptors, we see increase in the good stuff, BDNF, and that leads to more and more neuroplasticity. Now, there's another way to turn on BDNF, and that is infrared laser. And we'll talk about lasers a little bit more in just a minute. This is actually an image of a laser, a pulsing laser. And what happens when you pulse laser is that you get interactions between the coherent wavelengths. And so you get these little hot spots, like this little red dot right here, and then you get slightly colder spots. And this allows for, pulsing allows for more, a deeper penetration into tissue and delivery of more energy to tissue, just to explain the image you're looking at. So ketamine, you know, I'm sure you've heard of ketamine. You've read the newspaper reports and seen the claims on the internet, and it's all the rage. And you know, the problem though is the model that was designed for delivering ketamine is flawed. It was based on a study in which they did the first multiple infusion studies. There are several studies where they just gave people, you know, one infusion of ketamine, compared it to a control. And then they said, well, let's see what happens if we get multiple infusions. So they did 6 infusions in 2 weeks. Now, I, being a curious fellow, called up the principal author, the guy who did the study, and said, how'd you come up with 6 infusions in 2 weeks? What's the molecular mechanism you're trying to take advantage of? He said, I don't know, it just sounded good. It's what we do for ECT.
Yeah.
That was the science. That was it.
Yeah.
So when I started looking at ketamine more than 10 years ago, I realized what ketamine was actually doing, turning on BDNF. And I realized that neuroplasticity takes time. An axon grows a millimeter a day. So you can't rush it. It's going to take weeks. So when I designed my model and my approach to delivering ketamine, it was to give ketamine infusions no more than once a week. And in fact, it typically would be like week 1, week 2, week 4, week 7, something like that. And as a result, I get very, very different levels of response and remission. Now, there now have been 3 national studies that looked at response and remission in, quote, real world settings. These are clinics that are part of a company or a whole bunch of random clinics. And then there was a meta-analysis of smaller studies that were done, including my study. And what they found was the response rate to ketamine, which, you know, we used to talk about, oh, it's 80% response rate, it's a 70% response rate. Well, the response rate across all these clinics is 45 to 53%. And the remission rate, that is people who get to the point where they are not depressed, is 30%. Now, in our model,
And did they use the same dosage schedule per kilogram over there?
essentially, yeah, they're all about the same. They're all following. There's another flaw that I'll get to in just a moment about ketamine and other clinics. What I did was I have you know, collected data, because I'm a scientist. I collected data on all the patients who had ketamine, depression scales, multiple depression scales, as well as their dosing and their duration of response, et cetera, et cetera. And what we found is, on average, our patients get 4.3 infusions in their lifetime. So not 6, not 6 plus boosters, 4.3. And a response rate is 73%. And a response rate being defined as a 50% reduction in their depression scores. And a remission rate is that their depression scores drop to the point where they do not meet the definition of being depressed, was 49%. So a lot better. Now, there's another problem with how ketamine clinics are approaching this problem. I mean, I've been operating a clinic for 10 years. I had the 13th clinic in the country, the first clinic in Colorado. We followed the same protocol all of that time, no more than once a week. The clinics that are out there that are doing the 6 infusions in 2 weeks, they do 2 things wrong. Number one, people don't get better in 2 weeks. The neuroplasticity doesn't happen in 2 weeks. Number two, they escalate the dose. They start at the standard starting dose of 0.5 milligram per kilogram over 40 minutes. And then they escalate it to things as high as 2 milligrams per kilogram, which all that does is make people miserable, make them nauseous, and it doesn't make the neuroplasticity go any faster. So in fact, right now, there's a worldwide shortage of ketamine, because at this point, you can't swing a dead cat without hitting a ketamine clinic, and they're all giving it too often, and they're all giving too much. So you now have,
So why hasn't, why hasn't the powers that be, I guess because this is a cash model, so insurances aren't regulating it. So if you're willing to come in and pay for your next infusion, I've had patients that do the IV once a month. We have patients that we've used the nasal spray and the troche, the mouth troche, which as you have enlightened me, does not have the right racemic model in the drug, so that it's as effective as the IV. So I think that there's all of this confusion in the space because it's not regulated by reimbursement to some extent.
I'm not sure if reimbursement is a regulating factor other than because I think
limiting factor
in the business of making money, not treating people.
Right.
The FDA has started talking a little bit about ketamine infusions, somewhat critically. But at this point, there has not been regulation so far of ketamine infusion therapy.
You're right. I know they're going to
Let me
regulate.
show you some just real numbers,
Yeah.
So Dr. Hopkins mentioned evidence-based medicine a little bit earlier. Well, this is what real medicine looks like. These are QID scores, a quick inventory of depression symptomatology. So higher the score, the worse your depression. And you can see, here's a patient who their depression, in fact, got worse. It started out here, 20, shot up here, came back down. Here's a person who responded very rapidly. And you can see it's just like spaghetti on a wall. So everybody has their own individual response. And this is what I teach my patients. And I want my patients to be as smart or smarter than their doc when it comes to their medications. So I spend a lot of time with inpatient education. And I really emphasize to patients that, number one, you're going to have your own individual response. And number two, the hardest part of being a patient is being patient and waiting till things begin to work.
Are most of these patients on an SSRI or some sort of antidepressant?
Great question. Yeah. In my clinic, you have to have failed 3 antidepressants for me to consider you a candidate for ketamine infusion therapy. Most patients are on something. I wouldn't say not all of them are on something in terms of an oral antidepressant. I don't promise people that they'll necessarily get off their antidepressant, but a fair number do. And in fact, I devote a whole chapter of the book to sort of questions and answers about medications and other things that people worry about, like, what if I have bipolar disorder? Am I a candidate for ketamine? Or what if I use marijuana? Is that going to muck up my ketamine experience, et cetera, et cetera? So,
and when you speak about the 49% remission rate, how long is the remission for on average? I don't know if you have data regarding that.
Yeah, that's a great question. So the folks who reach remission generally have remission for a number of years. For example, I start off the book with Beth, and Beth is granted permission for me to use her name. And she suffered for over 40 years with depression. And this is what she has to say. This has been a miracle. I have been depression-free for 4 years. After 40 years of depression, each day is now filled with joy and gratitude. I've been able to travel extensively. I've been to Australia 3 times. I can enjoy my artistic and creative soul again. And she continues to be depression-free. She sent me an update email here a little bit ago, and continues to do well. And we're coming up on 5.5 years for her, just as an example.
Have any of your
Are there any
patients?
patient? Oh, go ahead. I was
Okay.
going to say, is there a patient profile in your experience that is predictive of a better response, whether it be number of comorbidities you have or some other factor that you think also helps predict success?
Unfortunately, no. And there's about a 24% response or lack of response. So at the time I did the study back in 2016, it was a 20% response rate. Now, it's gone up. I don't know if that's because I get more difficult and more challenging patients or not. But I can answer the opposite question, which is, what's it mean if you don't respond? I mean, it'd be great to be able to say, yeah, you're going to respond. It's worth spending the money. But what I can say to people is, you got a 72 to 74% chance that this is going to work for you. And if you don't, then I know some of the answers as to why not. And the second half of the book is devoted to talking about why ketamine didn't work for some individuals. And there's really 3 main reasons. Number one is just tricky genetics. And I wish I could say that getting a Genomine test would solve that problem, but it generally just tells you about your liver. It doesn't tell you about your brain. So, those folks where it doesn't work, I roll up my sleeves and I start trying different combinations and different approaches. I have some other ways of treating depression that are innovative, and retooling medicines that were designed for something else. And number 2, and this is where Dr. Hopkins and I come together, is that often people who do not respond and have depression, in fact, have a traumatic brain injury. And you wouldn't expect an injured brain to respond to a chemical the same way an uninjured brain would. So it's not surprising that people with traumatic brain injury do not necessarily respond to ketamine, even though ketamine has that neuroplasticity ability. And traumatic brain injury leads us naturally to talking about the laser in just a moment. The third is that some people who have depression, in fact, have an infected brain. And this is another area of that where medicine is just going to stand on its ear. So evidence is now becoming more and more clear. For example, that chronic fatigue syndrome is in fact caused by certain viruses, in particular the herpes family of viruses, such as Epstein-Barr virus and herpes 6. Mayo Clinic, the place that doesn't believe in chronic Lyme disease, published a paper saying that herpes 6 is involved in bipolar disorder. We now have very, very clear evidence that herpes 1, the cold sore virus, plays a major role in Alzheimer's disease. So we're beginning to see these connections, not just in psychiatric illnesses, but also in what we traditionally thought of as neurological illnesses, including things like MS, multiple sclerosis, and ALS, or Lou Gehrig's disease.
Which
So
brings me to
very-
some of the treatments. We're getting more patients with multiple sclerosis. And what is frightening to me is the use of immunosuppressants such as rituximab, or now called Ocrevus, which
Mhm.
is lowering their immune system to a point where their lymphocytes are depressed substantially, while I am measuring antibodies to herpes 1, herpes 6, in that they have
Epstein-Barr.
Epstein-Barr, John Cunningham virus in the brain, which acts as a prion disease, should it be activated while you're on immunosuppressants. And that virus came to light during the AIDS epidemic, I guess we'd call it. And even with the AIDS patients, it was the use of many of the drugs to quote treat AIDS, then allowed for the blossom of the JC virus. Yet we don't see, when I bring this up to the doctors at the MS clinic, and I am dismissed summarily that this is a non-issue, which is hard to believe because the patients are deteriorating in front of my eyes and they continue to use the same hammer, but there's no nail. They're going right through the wood. It's pretty amazing to me. We just had the International Lyme meeting this past weekend in Boston. And again, the neuro Lyme and the association with chronic biofilm diseases. And I'm really bringing this up for so many patients who have had Lyme, if they're having cognitive decline, that we go back and measure the we use the IGeneX lab in California to look at their PCR and their FISH scores and look at Bartonella, look at Lyme, see if there's activation of the Epstein-Barr with early antigen. And I think we have to address it. And so far, I will say in town, the door gets shut pretty quickly and I raise this issue.
Mm-hmm. And just to say it out loud, there is clear evidence that Bartonella and Babesia, as well as Lyme disease, Borrelia, cause psychiatric symptoms and cause neurological symptoms, and that can be, they can be deadly.
Yeah.
Yeah. All right, let's see what happens next. Well, let's talk about lasers for a minute. What does laser therapy look like? Well, it's essentially a painless and safe application of infrared light. You have to, as we'll talk about, deliver enough infrared light that it can get through this overlying tissue to reach the brain. And when it does, when your infrared light can get through all of that, it reaches what's called the mitochondria, the little organelles that are the energy manufacturer organelles within the cell. But mitochondria also have their own genes. And in fact, they have 111 genes. And infrared light activates those genes, which result in signals being sent to your chromosomes, which turn on other genes that are involved in things such as cell repair. So the growth factors such as BDNF gets turned on by infrared light therapy if it reaches the neurons. And that induces neuron repair, new synapses, stem cells transforming into active neurons, as well as increasing inflammatory mediators. So in general, infrared light reduces inflammation. And this is where infrared lasers began. I mean, their original application was to treat joints. One of my colleagues here in Colorado worked with the Saudis racehorses. So they put the racehorse on a 747, fly it over. He would treat the horse's legs, fly it back, the horse would be able to run again. So the original application of infrared light was really for inflammation. Now, hopefully you're not trying to eat dinner while you're listening to this. I apologize in advance. But this is some of the data out of a little university called Harvard that's, I think, somewhere around Boston. And this is a slice from a healthy mouse brain. And here's a slice from a mouse who received a structured or a uniform brain injury. And here's a mouse that got the same uniform brain injury, but they were treated with infrared light. And they've shown, and others, University of Texas Southeastern, et cetera, have shown that, in fact, this is infrared light turns on dendrite formation. So here's traumatic brain injury, here's traumatic brain injury plus infrared light. And you can see how the dendrite marker, which is green, is increased. And the same thing with synapses shown with this red marker. And just a little bit more science-y data here. Here's that BDNF, and it's hard to see, but it's these little purple guys that right there, and you can see a whole bunch of them here. If you treat the animal with infrared light 3 times, you get this marked increase in BDNF. Now, the problem is that a mouse's scalp and skull is about the thickness of 6 sheets of paper. And so you can take a 1/2 watt LED and you can treat a mouse. You can put that over the mouse's head and it will reach its brain. Not so in a human, because the scalp and skull of a human is much thicker than that. It's about 90 sheets of paper, and some people's skulls, such as mine, are much thicker than that. So you have a 1/2 watt LED is not going to get through that. In fact, a 1/2 watt LED only gets not even a full millimeter, just 0.8 millimeters into human skin. So when we were looking at this very early on, my colleague, the late Dr. Larry Maurice, and I wanted to figure out how to grow up what Harvard was doing in mice so that it worked in humans. And so we literally went into the research lab and started with sheep heads and worked up to working with human material, including eventually living human tissue. Dr. Henderson's hand is exactly 25 millimeters thick. And since it's skin and bone and tendons and muscle, it's a good model for penetrating, say, the side of the head to reach the temporal lobe of the brain. And we published that back in 2015. The other thing we figured out that most people ignore is there's a problem with hair. So here is a 10-watt laser separated by 3 millimeters from a meter, and the meter is reading 9.79 watts. So even that 3 millimeters of air drops the energy a little bit. And then we put hair in that 3 millimeters, and look what happens. Only 0.236 watts gets through, and we're delivering 10 watts. Now, I'll tell you what happens is the hair, the infrared light gets inside the hair and bounces around like a hall of mirrors and begins to heat up the hair. So it took about 3 weeks for my poor technologist to stop smelling like a burnt chicken. Not happy.
At least it wasn't your hair.
Well, yeah, it would have been hard to get it in there. Now, so here's what's out there. You can go out and you can spend a couple $1,000s and you can buy this little contraption that sits on top of your hair and has 1/2 watt LEDs. And you can shove a 1/2 watt LED up your nose, or you can have this helmet that sits on top of your hair, or et cetera, et cetera. And you see the problem already. These are all delivering a 1/2 watt of LED light, claiming to treat the brain, and they're not even getting through the hair. So this is part of the problem. And this is part of the confusion in the field. And it's one of the dangers to infrared light. This kind of nonsense will make people stop believing in what infrared light is doing. And that is one of my big beefs in the field.
Why are they doing the nasal flip? What do they think that is doing? Is that shooting the light up through the nasal cavity to the base of the brain? Is that what they were implying?
They can't claim that they're passing light through the sinuses, but it doesn't even get through the mucosa, and then once it gets through the sinus, it's going through bone, and then it has to go through air, and then has to go through another bone, and then it might get to the base of the brain, but they don't even get through the mucosa.
But it might help like acute rhinitis or something, right?
It might help acute rhinitis, and it's certainly possible that it could help the olfactory epithelium in people who have anosmia after COVID.
Mm-hmm.
So that's been shown to be at least somewhat effective.
So one thing that we had discussed, I know, about the inefficient penetration of the light at these, less than 1 watt lasers. And Dr. Irani is another one of our colleagues that Ted and I have been working with over the last couple of years, looking at, well, can the blood flow through the area bring signals back to the brain? So the blood flow in the nasal mucosa, even with a low level watt laser, might be triggering some signaling, but it's hard to measure the effectiveness. So that's why I tell people this is not a red flashlight. You cannot go out and buy a red light bulb and think you're getting infrared light treatment.
That's very correct, and you lead me to a discussion of what's called indirect photobiomodulation, and as opposed to direct. So these guys claim that they're treating the brain. Well, they may be treating the skin, and in fact, the skin is then carrying some signal, maybe via blood, to the brain, which could be beneficial. Now, that paper is forthcoming. I'm writing that paper now. I presented that data at a meeting on October 10th. And essentially what we were able to show was that by irradiating the forearm, I was able to invoke changes in the QEEG of the brain. And in fact, we took that study one step further. We got a volunteer, namely me, to wear a blood pressure cuff, with the pressure increase to the point that there was very little arterial pulse and no venous drainage. And then we did the same experiment. We irradiated the forearm, and there was no change in the QEEG activity. And then we released the blood pressure cuff, and the alpha power of the QEEG jumped dramatically. So it bears, and there's actually extensive research on other forms of indirect photobiomodulation, but these guys don't want to, be talking about indirect photobiomodulation. They want to continue to claim that they're directly treating the brain.
Well, that's the benefit of the Theralite bed, which we do not have. We have the Aspen laser, but that there would be some improvement through indirect therapy. And I think it's important to be very clear about expectations and the use of these various technologies.
Right. So,
And are you running with these lasers? Are you just running infrared, or are you doing red as well?
the laser that I use was built by Aspen Laser to my specifications. So we have red light. I generally am not using red light for the brain. I use that for inflammation. And so we're using 810, 980, and 1064. This study was done with just 810 and 980. It was published back in 2017, again with Dr. Larry Maurice, my colleague who is now deceased. And what we were looking at was depression scores. In this case, again, using the quick inventory of depression symptomatology. And at baseline, patients had, moderate depression, score of 15 on average. And it dropped dramatically. And what was notable is that they continued to remain well for, 3, 4, 5, 6 years later. Now, depression, I expect to come back because we're not treating the genes, we're just treating the brain. And so the genetic mechanism responsible for depression in people who have intrinsic depression, that is genetically based depression, the mechanism is going to continue to percolate. Now, Paulo Cassano at a little place called Harvard did a study using a 5-watt laser, and we were using 13 watts. And he got some depression improvement. The P was 0.031. Here's our P. So essentially that's 0.00000000645. He did not see any persistent benefit. The patient's depressions returned as soon as they stopped treatment. This is also what you see with all of these devices. As long as you are doing this, you'll see some improvement in your traumatic brain injury symptoms or whatever, but as soon as you stop treatment, they start coming back. At that meeting, they presented some data on post-COVID fatigue, exactly the same thing. As soon as they stopped treatment, it started to return. Similarly, they were talking about autism. They saw some improvement in autism symptoms, slight improvements, but as soon as they stopped treatment, the symptoms started to
Well,
return.
that's the problem when I've gone on Harvard is starting a photobiomodulation laser clinic, but they never mention what laser they're using, and I can't get anyone to describe how they're using it and in what manner it's going to be used and even how you access it. So
yeah, it's basically a pad of lights, and it's kind of strapped onto your head for a 20-minute treatment.
And maybe Dr. Henderson, go back to the previous slide and just show our listeners about, so the real difference, as you're saying, is power,
Yeah, the difference here is the power. You
right?
have to have, I mean, 5 watts is not going to reliably get to the brain, and and you have to understand that, you know, if you're if you're passing light through materials such as scalp and skull, it's losing energy. It's getting absorbed, it's getting scattered, and so once you get to the brain, you still have enough energy to actually activate the mitochondria. It's not just one photon. It has to be enough power that it activates the mitochondria. And I could go into all that math, but I thought that was a little over the top.
No, I think the message is power matters.
Power does matter. So just give you one example of traumatic brain injury. This is Eric, and he's signed a release, so I can talk about him freely and show his picture and show his MRI. He had a injury in the line of duty 32 years prior to the time that he was treated. And you can see this white area here is scarring on an MRI. So that's dead tissue. And that corresponds to this site right here on this SPECT scan. A SPECT scan is a functional brain scan. Color matters on when you're looking at a SPECT scan, unless you're looking at something from the Amen Clinic where holes matter. But in these kinds of scans, the color scale, yellow is normal activity, red is a little overactive. So you can see, you know, most of the brain is green, so it's not doing so hot to begin with. Light blue is worse, dark blue is worse, black is essentially considered to be dead. So here we got these areas, you know, matching the glial scarring, but all this area around the brain is just limping along. And here's this area that could well be dead. And looking from above, here's the opposite side of the brain. You can see how severely affected the opposite side of his brain is. And here he is after treatment. That area of brain is still dead. I'm Dr. Henderson, not Dr. Frankenstein.
Mhm.
But look at this. This area here wasn't dead after all. It came back a little bit. And all these other areas that were dark blue and large areas blue now are looking much better. And even the opposite side of the brain is looking much better.
And how many treatments did you give him?
He received, I mean, it's all very individualized, but he received about 30 treatments at the point between, you know, the before and after images were done. He got subsequent treatments and had additional improvement, but we didn't do another SPECT scan.
And are you doing twice a week or once a week?
Twice a week. And that was back before we added the 1064. That was with a very old Aspen laser. And here's all the symptoms he had. And here's what he had after treatment. He still had some memory problems and some cognitive problems, but his concussion scale scores improved dramatically. Pupil constriction latency, which is, remember on the movies and the old movies, the doctor would flash a flashlight in people's eye to say, oh, you've got a brain injury or you're fine. That's looking at pupil reflex, how quickly your pupil constricts to light. And that can actually be measured very precisely in seconds and milliseconds. And it's an important physiological measure of brain injury. And so you can see that his latency, that is how long it took his pupil to start to constrict, got shorter. That's a sign of better health. His short-term memory improved somewhat. This young lady had the misfortune of falling out of a pickup truck at freeway speed. And here's a quick look at her SPECT scan. I won't belabor it too much because I just want to kind of point out that her symptom improvement was so dramatic. And here's her brain scan, her SPECT scan with a different color scale. And what the color scale is, just very briefly, is that gray is, this is comparing her brain to a normal database. People who don't have a brain injury, don't have a psychiatric diagnosis, don't use drugs or alcohol. All the areas of gray are within 2 standard deviations of the mean of the normal database. Green is 2 to 3 standard deviations below, light blue 3 to 4, dark blue 4 to 5, and greater than 5 standard deviations below the mean of the normal database is black. So you can see these 2 areas that look very severely affected on both temporal lobes, and you can see how much those improved with treatment. Again,
And was this with the new laser, the 20?
No, this is back in 2017.
Okay.
It's still just 810 and 980. And it was about, we were working with about 12 watts. This one of my favorite patients, police officer, had a brain injury, was severely depressed. And I talked to her about what we're going to be doing, and I said, hey, hair kind of gets in the way, so can you maybe cut your hair a little shorter on the sides, at least so we can get to your temporal lobes, because that's where some of the action is. And she shows up for the first appointment, Sinead O'Connor. And I love this officer. She just said, hair will grow back. I need my brain.
Wow.
So here's
Wow.
what she was struggling with: headache and severe depression, very suicidal, could not take care of her kids. And after that, all those psychiatric symptoms and neurological symptoms resolved except the headache.
Now,
And
in
this-
some of these, did you
Okay.
combine therapy with ketamine as well?
Oh, well, that's a great question, which I'll touch on in a minute.
Okay.
In her case, no.
To the wife and mother, the light has been a lifesaver. It's miraculous. I was literally in bed in the fetal position all day long. It's giving me my life back. Her husband, Dwight Draper, agrees. This former police officer swears by it.
So just a little plug for that. Overall, looking at patients across that we've treated with traumatic brain injury, this is sort of the response that we're seeing. Red is before treatment, green is after treatment. Everyone has sleep issues. If you've had a concussion or brain injury, your sleep is going to be messed up, and that resolves quite well. Irritability, mood problems, depression, anxiety, all respond quite robustly. Headache, less so. That's the true. The other one that we've not been able to lick as well is photosensitivity. So people who have can't deal with fluorescent lights, for example. Although many people who haven't had a brain injury can't deal with fluorescent lights. And just to touch on something else, Parkinson's disease, we're having some really good luck with Parkinson's. I just will touch very briefly on that. So here's a patient before, their handwriting before treatment. Here is after treatment.
Do you do the whole brain, or do you focus on?
We are targeting the substantia nigra, which
Nigra.
involves kind of getting around and behind the ear. And here's one of our patients. He started with masked faces. I wish I had the picture of the before, but I don't. But here he is. He's able to smile again.
Well, I was concerned about the steady track of taking more and more of my medications, and what I noticed is that the slope leveled off, stopped increasing, and then it actually decreased, so that I was able to get by with less medication.
And post-COVID fatigue, we've seen some really good luck with that, treating both the lungs and the brain. And ADHD, this is fascinating. So this actually grew out of some of our, we had a little bit of data, but since we've been treating a lot of people with post-COVID fatigue, 10% of them come in, they have ADHD, and they've been on, stimulants their whole life. Here's an example of one of the kids that we treated before.
I got bonuses out of the treatment. You don't think I'm ever going to have to get an ADHD medication refilled. I don't think I'll ever need a benzo again.
That's after 20 treatments for post-COVID fatigue. And he's a dentist in a very, very busy practice in Florida. And I talked to him about once a month, and he continues to do well. And he's, a year, 8 months out from treatment.
And how
And
many
what part of the
treatments?
brain are you treating with ADHD?
Frontal lobe and temporal lobe.
I do find patients when I do the occipital lobe, where your dopamine is concentrated, and they're like, wow, I leave here so happy. And I'm like, and the other benefits. And one patient said, I was coming up here for my 6th week driving up from New York. So when patients say to me, well, I don't know if I can fit it in, I go, I have patients that drive from New York City here, because Amin doesn't do laser therapy. And he said, my wife just texted me, you're back. And he was a COVID vaccine injury with seizures and tinnitus, and had resolution of his symptoms. So I really want to thank you for the time that you've made for us. This is an amazing story, and I hope people have learned. And when people say, what keeps you going? I say, coming in and seeing you. And I had an 80-year-old recently, after one treatment, she was like, wow, I haven't slept that well. I feel energized, and said my memory in one treatment is coming back. So this is always the exciting part for us. And that's what, Leslie and I have been focused on over the last 10 years, which is to provide treatment that moves your wellness into focus and provide you with opportunities to have healthgevity, not just longevity, because I think that is something we all struggle with. And certainly I think what we're seeing is healthgevity is getting less and longevity is getting more. So we're going to have people, 40 years living with chronic illness and reliant on medications. So we're hoping to obviously mitigate that tragedy and to improve to the best of their ability. So I know we're at our closing time and dinner time here. So we'll let everyone get to dinner. And I just want to thank Dr. Henderson for coming on this evening. And you will be getting a recording of this will be up on the website, a link to his new book, which was delightful and enlightening. And his own story is enlightening as he carries you through his life's challenges. In his successes. He's a musician and a jazz musician and just an overall amazingly talented person. And to him to give us this time tonight, I just want to thank everybody. And we will see you. Be patient as we transition to our new electronic medical record. We onboard new staff and providers, and we continue to provide the care that you all need. So thank you so much. And thank everyone who stayed with us this evening on our fall town hall. Ted, thank you so much. And we will be in touch on some new exciting issues.
There you go. All right.
Thank
All
you,
right.
Dr. Henderson.
Take
pleasure,
care,
my pleasure.
everyone. Good night.
Good night, everyone.